Hello, my name is Professor Fergal Malone. I'm the Professor and Chairman of the Department of Obstetrics and Gynaecology at the Rotunda Hospital in Dublin and the Royal College of Surgeons in Ireland. I'm also a consultant obstetrician here at the Rotunda Hospital, and I'm the principal investigator for the Home Induction Trial. The Home Induction Trial is a prospective randomized study to compare three different methods of inducing people at term in the outpatient or home setting. This is very important because induction of labor is becoming more and more common, but it puts huge demands on hospital resources, as well as being potentially quite inconvenient for patients, because it means patients are generally in hospital longer than they'd want to be. If we could come up with a mechanism by which we could commence the induction, the slower part, the slower phase of the induction in a setting such as the patient's home, it would be much better for hospital resources, but also much better for patient satisfaction. So we've designed a trial where patients on their first pregnancy at 39 weeks who are otherwise healthy get randomized to either placing prostaglandin gel substance around the cervix for up to 24 hours, or else placing an inert dilating rod into the cervix for either 12 or 24 hours. The hope is that after that 12 or 24 hours is up, the patient will come into hospital in the early stages of labor, or at least much more favorable for commencing the rest of the labor process. For many years, there was a concern that induction of labor might be associated with long, slow labor and potentially resulting in a cesarean section. We now know from other research that this is not necessarily true, and in actual fact, if you compare how women do in their first labor from being induced at 39 weeks versus waiting for spontaneous labor to start naturally itself, the lowest cesarean section rate is actually in the group of patients who were induced at 39 weeks. Some patients on their first pregnancy at term who are otherwise well will ask themselves the question, should I wait for labor to start spontaneously, or should I consider induction? For many years, the traditional thinking was, let's just wait for labor to start naturally, because spontaneous onset of labor is usually the most efficient, fastest labor and results in the lowest chance of problems such as a cesarean section. However, it's impossible for any patient or their midwife or their obstetrician to know at 39 weeks, is labor going to start spontaneously in the next short while? Or are they going to find themselves at 41 weeks having to get induced anyway? So another option that's been looked at recently is for patients who are otherwise well and healthy at 39 weeks to consider just having an induction anyway. The reason for this is that if an induction is started at 39 weeks before the baby is too big, it appears to be associated with the lowest chance of needing a cesarean section. And this is actually quite logical when you think about it, because at some point, size matters. As every week goes on, the baby gains about a half a pound a week or 200 grams a week in size. And eventually, as each week goes on, the baby's size may become too large for that particular woman's pelvis. So in some randomized trials that have been done elsewhere, where patients at 39 weeks had been randomized to either having an induction or waiting for spontaneous labor, the actual lowest rate of cesarean section was found in the patients who were induced at 39 weeks, not the patients who waited. Now that there's increasing demand from patients to have an induction of labor for various reasons, one of the biggest challenges we've had is our hospitals don't seem to have the resources or the space to cope with such a large number of patients having a more prolonged time in the hospital waiting for their induction to succeed. In addition, not many patients like being in hospital for a prolonged period of time. If given the choice, many patients would prefer the earlier stages of their labour to be conducted at home in their own comfort environment of their own home. So a major problem that we looked at is, can we come up with a safe way of commencing induction of labour in the patient's home environment in a safe way, safe for mother, safe for baby. And this study looks at different ways of commencing the induction process in the home environment. The idea being that if it turns out to be successful and safe, then this will empower women further to have induction in the setting that suits them best. This trial focuses on women in their first labour who are otherwise healthy and have reached 39 weeks of gestation and have no other reason to be delivered or to have any other complication that warrants intervention. Once they're informed of the trial and decide that after weighing the pros and cons of participation that they want to participate, they're randomised to one of 3 different study arms. One arm is where they get a prostaglandin gel substance placed in the vagina for up to 24 hours and are then sent home with that in place, waiting for labour to start or waiting for the cervix to become a little bit more favourable. The second arm is patients are given an inert rod. Device is placed into the cervix and is left there for 24 hours to slowly dilate the cervix until labour starts spontaneously or they're more favourable for the next step of the induction. And the third step, or the third arm of the trial, is a similar arm as the second one, where an inert rod is placed in the cervix but left there for 12 hours in the hope that that also will start labour in that time period, or the rest of the induction process will be easier to do from that point on. The primary objective is time taken to successfully reach a vaginal delivery from the time that the induction started. We hope that one or other of the arms in the trial will show that one particular approach leads to a faster induction than the other. The other aim is to minimize the cesarean section rate and to see what is the overall successful natural vaginal delivery rate in the 3 different approaches. And then the other area that we're looking at is the overall safety and acceptability to patients of the different methods of induction. A trial like home induction is essential right now because of the increased patient demand for induction. With a large number of patients needing or seeking induction of labour, it is difficult to manage that large number of patients through a limited labour ward where you have only a certain number of rooms and beds available at any one time. So it would be a great help to both hospitals and patients if we could come up with a mechanism of inducing labour that keeps patients at home for as long as possible and supports a more homely, natural environment for the patient for as much of their labour as it is safe to do so.